Okay, our presentation on osteoarthritis and total hip arthroplasty. The patient case is Edna. She is a 67-year-old female. She has a history of hypertension, osteoarthritis, osteoporosis, emphysema, and smoking. She was diagnosed with emphysema 2 years ago and continued to smoke after her diagnosis. She retired 1 year ago, which allowed her more energy. She used to be a secretary, and now she isn't as tired during the day. At home, she does cleaning, shopping, laundry, and meal prep, and volunteers at the local hospital. She has been slowing down more over time and has generalized pain in her right hip. Current problem with her hip was the pain and difficulty rising from chair, showering, going in and out of her car, shopping and walking. Specifically, the steam affected her breathing. She had difficulty getting in and out of her tub, and she self-medicated with aspirin when needed. She had to avoid malls and her weekly shopping trips with her friends. Her physician recommended that she get a total hip replacement, but to do this she was required to quit smoking. This took her several attempts, and during this time she had a decline in her physical condition, which caused an increased amount of pain. She gained 20 pounds. She had to use a wheelchair for community mobility, and then she also had more decrease in participation in the community activities. We're now seeing her after her total hip replacement. It's 10 days after her acute rehab, and she was referred to outpatient. With the examination notes, currently she's partial weight bearing on her right lower extremity. She's pain-free at rest, but during activity like passive range of motion and active range of motion, she is at a 3 out of 10. She has impaired dynamic sitting and standing balance, secondary to her surgery as well as her partial weight bearing status. She uses a long-handled reacher and a shoehorn for her ADLs currently, and an adductor wedge, a rolling walker with a basket for ambulation, a 3-in-1 commode, minimal assist for tub transfers using a seat. Supervision is required for stairs to assist with her foot clearance, and she has not been cleared for driving as of yet. Her husband still performs all of her lower body bathing and dressing, also assists with meal prep, and spends more time at home to assist her. All of her other ADLs are independent or within functional limits. Her environment currently is a ranch-style home with one step to enter, a standard bathroom, and no barriers into the house. Range of motion is limited in neck, trunk, and hip due to osteoarthritis. Generally everywhere else is within normal limits. Strength in the neck is also decreased due to the osteoarthritis. She also has limitations in her lower extremity, in the right hip abductors and adductors, as well as hip flexors, extensors, internal rotators, and external rotators.
The treatments in the plan of care involve restorative techniques because the patient is fairly young and she should be able to return to near normal functional levels. The patient will be seen twice per week for land-based therapy and 1 time a week for aquatic physical therapy. The therapy sessions will continue for about 12 weeks, and we will adjust the plan of care accordingly. The plan of care will include improving range of motion in the neck, trunk, and right hip. We'll focus primarily on the right hip due to that being the surgical site, but also on the neck and trunk due to her osteoarthritis. We'll also work on bilateral lower extremity strengthening using closed kinetic chains, balance training, gait training, ADL training. And we will also use short, intense exercise using an arm ergometer. You'll hear more about the research on this later. So the plan of care progressions that we'll use, first we'll start with patient education on the home exercise program, transfer training, mobility training, and precautions. To progress the home exercise program, we will increase the reps, the resistance, and the time. We'll also work on progressing the independence on transfers and mobility, both with and without assistive devices. We'll also work on bilateral range of motion exercises, which can be progressed by increasing the number of reps and time spent performing those, and we'll make these functional activities. Trunk and upper extremity strengthening will be used, and these will be progressed by increasing the number of reps, the amount of resistance. We'll also make these functional exercises as well. Isometric strengthening of the lower extremity. We'll be able to progress this by increasing the amount of time spent doing the exercises. Dynamic strengthening of the lower extremity will be used. We'll both use open and closed kinetic chain exercises, and these will be progressed by increasing the number of reps, the amount of resistance, and the time spent doing them. We'll also work on balance and proprioception training. For balance, we can progress from bilateral or both legs to single legs, and then with and without vision. We can also progress to throwing and catching the ball and using a variation of wobble boards. And then gait training can also be progressed by increasing the amount of distance that she ambulates, as well as trying to decrease her time to make it more functional. We'll also incorporate tandem and sidewalking to help improve balance, strength, and coordination. We'll practice on uneven surfaces and moving towards independent walking, and walking gait training will also increase her cardiovascular function. The patient goals that she has for physical therapy includes to be independent in her self-care without any equipment, including showering and getting dressed. She would like to be independent in her transfers without an assistive device, which includes showering. The patient would like to be independent in ambulation either with or without a straight cane. The patient would like to be at an ambulatory level for home management tasks such as cooking and cleaning. The patient would like to return to her volunteer position at the hospital, as well as return to other community activities. The goals for physical therapy that we have for her will be completed in 8 to 12 weeks. These include patient being able to be independent in dressing and washing her lower body with the use of a shower chair. The patient will be able to transfer in and out of a car independently with good body mechanics to increase independence in the community. The patient will also be able to ambulate at least 300 feet independently on even surfaces without an assistive device in order to shop with her friends. The patient will be able to tolerate 3 hours of volunteering at a hospital with no more than 2 rest breaks per session, so she can return to that. The patient will return bilateral lower extremity strength to within functional limits in order to have successful ambulation and transfers. The patient will achieve right hip range of motion to within functional limits to improve ability to dress and wash her lower body independently. And the patient will achieve range of motion to within functional limits in the neck and trunk for improved ability to complete ADLs and ability to drive.
Alright, so the first study that we read through was about hydrotherapy after a total hip replacement. This was a prospective randomized study, and it was done with the elderly population. Every subject they had was post-total hip in less than 10 days out of the surgery. There were 2 treatment groups. So one group received hydrotherapy, the other one received conventional rehabilitation, so what would normally happen for a total hip. These groups both worked for 6 times a week for 3 weeks. They were evaluated on an osteoarthritis index, the WOMAC scale. And this evaluated the pain, stiffness, and function. It was subjective as a questionnaire and was administered at admission, discharge, and 6 months after by a follow-up phone call. This WOMAC scale was actually one of the issues that was happening with the study due to its subjective and no objective measures. The results of the study were that hydrotherapy treatments were just as effective as the conventional rehab, and they actually lasted longer and had better lasting effects than the conventional rehab. They also found that there were psychological benefits for the elderly patients for aquatic therapy from the safety and the general good feel of being in the pool environment. And the limitations, as I mentioned before, with the WOMAC only being the only dependent scale, they also said that there's no overlap of performance measures, range of motion, or radiographic measures, so we weren't sure if the study was very objective or if it was just the patient's perceptions. There are also no physical or functional measures. And the strength of treatments were that everyone had equal time and frequency of the treatment, so they were able to determine which ones were better and not limited to the time that they were given, and there was a large number of subjects.
The study that I reviewed was resistance training in the early post-op phase in the elderly hip surgery patients. This was a prospective randomized controlled trial that consisted of 36 patients that had a unilateral hip replacement. The patients were randomized into 3 different groups. The first group was the home-based standard rehab, where they received just your conventional physical therapy 1 hour a day for 12 weeks. The second group was the same home-based standard rehab, but it also incorporated unilateral lower extremity resistance training, and this was 3 times a week for 12 weeks. And then the final group was the same home-based standard rehab with the addition of unilateral neuromuscular E-stim, and this was applied for 1 hour a day for 12 weeks. The outcome measures of this study looked at the length of stay in the hospital, the quadriceps cross-sectional area, isokinetic muscle strength, and functional performance. As far as internal validity, the study had very good randomization procedures, and the clinicians that were taking the measurements were blind to the intervention, so they didn't have any bias. However, the study did not account for any pain levels, which may have impacted or limited the outcomes. As for external validity, the study had strict inclusion criteria to determine the eligible patients, and there were no differences between all of the groups at baseline. However, the study had a very small sample size, so for future research, the study should be repeated with a larger sample size to increase the strength of its findings. The results of this study showed that the resistance training group had an increase in muscle mass, an increase in maximal muscle strength, and an increase in functional performance over the standard rehab group. The study also showed that resistance training had a decline in the length of stay in the hospital compared to both of the other groups. This study is very important to PT. According to the study, muscle strength declines about 4% every day during the first week of immobilization. Therefore, it is important to start physical training and resistance training early for patients that are post-hip replacement.
Okay, so this study examined the effect of initiating the physical therapy, like I said, on the day of surgery. The authors of this study specifically wanted to assess whether or not the shortened length of stay would result in patients being discharged with fewer functional milestones reached. Some of these functional milestones included the ability to ambulate stairs and the use of assistive device. The physical therapy that was performed on the day of surgery included bedside evaluation, dangle of the lower extremity, standing, ambulating, and weight bearing as tolerated. Bedside exercises, patient education, and total hip precautions were also given on the day of surgery. Prior to this research, the clinical guidelines called for these interventions to instead be implemented on the day after surgery. So with this study, there was strong internal validity. There was a reliable procedure for selections of the group. They spent time a week before the study, matching the patients between the two groups to ensure consistent comparison for level of care. There was 480 subjects total in this study. 408 total. 204 were in each group. The mean age of each group was 60 years, and they used the following descriptive variables to split up the groups. And these were age, gender, race, BMI, site of surgery, day of the week surgery was performed, preoperative device used, preoperative maximum distance ambulated, presence of stairs in the home, and social system at home. And they used all these variables to evenly split up patients within the group. Patients with certain comorbidities were excluded from the study. These include stroke, multiple sclerosis, Parkinson's disease, post-polio syndrome, nerve palsy with drop foot, Alzheimer's disease, dementia, and seizure disorder. So the strength of external validity in the study included all the topics that I've just listed. A weakness of external validity in the study was that the time of treatment was not recorded for either the day of the group that received surgery, the group that received therapy the day of surgery, or on the group that received surgery on post-op day 1. Post-op day 1 was simply considered as the calendar day following the day of surgery, and this discharge time could have been more accurately quantified if the authors would have examined the results based on hourly intervals versus simply the calendar day following day of surgery. So the results of this study were that the patients who received PT interventions on the day of surgery stayed an average of 0.21 days less in the hospital. And this may not seem like a lot, but this specific hospital performed hundreds of thousands of total hip arthroplasties per year. So that number extrapolated over the couple 100,000 really makes a difference in the efficiency of healthcare dollars being spent on patients staying an excess amount of days in the hospital. And the reduction in the days stayed in the hospital came with no difference in functional outcomes being met. And the relevance with this, obviously, to PT would be that with the rise of healthcare dollars and with the push to get patients out of the hospital as soon as possible and out of the ICU, it is definitely appropriate to begin therapy on the day of surgery in patients who had unilateral total hip arthroplasty versus waiting till post-op day 1 to initiate the physical therapy. And the study shows that it can be done without sacrificing the ability to perform functional tasks. Some limitations to this study include that the number of comorbidities that were excluded. A lot of patients that report to the hospital to have the total hip arthroplasty are going to have the comorbidities, so it would be nice to see a study done including a patient population with the comorbidities that were excluded. And that could be a possibility for future research with this study.
Lastly, our last article was about arm ergometer training within a total hip population. It was a randomized controlled trial, 14 elderly participants over the age of 65. The median age of the participants were 77. 12 females and 2 males all underwent a total hip arthroplasty. The total hip was either cemented or not cemented, so they took both types for participation. All participants also had a main diagnosis of hip osteoarthritis, such as our patient, and it excluded participants that were undergoing revisions, taking specific medications that could interfere with high-intensity exercise and severe cardiac complications. Pre- and post-tests were taken, one being incremental exercise test with an arm ergometer, and as well as a 6-minute walk test. The 6-minute walk test also measured respiratory gas exchange. The duration of exercise and ventilation threshold were also measured as well. Pre-tests were taken 1 month prior to the surgery, and post-tests were taken 2 months post-op. There was 2 groups. One, the independent group, underwent general rehabilitation. General rehab included range of motion, strength exercises, aquatics, and walking for 2 hours a day. The dependent group also went under this general rehabilitation, but they also went under a high-intensity arm ergometer training, which was done 3 times a week for 30 minutes. It was divided into 6 intervals of 5 minutes. The first 4 was at a base workload that was determined per participant, and 1 minute at a peak workload that was determined. It was found that the dependent group that went through the arm ergometer training did have increased peak values in walking ability. Both groups had similar peak values at the beginning prior to their surgery. After training, higher peak VO2 was found in the dependent group, as well as ventilatory threshold and power output. The interval group also walked significantly longer, as well as at higher speeds. And the higher speeds that were determined also didn't have an increase in their RPE time, so they were walking faster and longer without any kind of increase in stress. Stride length and cadence were also higher in the interval group, and in general, ambulation was more efficient. The control group did go back to their baselines after surgery with just general rehabilitation, but there was no improvement. Problems with the study was that it was a very small sample size. There was only 14 people, but because of the significance between the statistics, they believed that this would promote or undergo more research with higher sample sizes. Also, all participants were still considered to be at a deconditioned state at the end of the training program, so they all started deconditioned, and even though the dependent group did improve, they were all still at a deconditioned state. So theories are now being proposed on whether or not we should start this type of training prior to the total hip arthroplasty.
So some comorbidities and age-related changes. They include emphysema, osteoarthritis, osteoporosis, and hypertension. And these will require additional monitoring during the PT sessions. And it's necessary to review the list of medications that patient will be on due to the possible effects with exercise. Other age-related changes include decreased bone density, which lead to increased risk of fractures, some decreased reaction times and a fall risk, slower healing, in addition to smoking, and decreased visual acuity. And it's just important to keep these in mind when performing some specific interventions and how they could change the plan of care. Some precautions to keep in mind: avoid hip flexion greater than 80 to 90 degrees. So this would include bending over to pick something up, sitting in a chair that is too low, picking your leg up to tie their shoe, etc. Avoid hip adduction and internal rotation beyond neutral. So you could explain to the patient it could be detrimental to sleep and side lying. When they're sleeping, they should be supine with an abduction wedge. Postpone dynamic strengthening for about 6 weeks. So as mentioned earlier, you would want to start out with more of the trunk and isometric strengthening. And for ADL precautions, basically anything that is going to cause excess force on the femoral head that would possibly lead to it being forced out of the acetabulum, so don't cross your legs. Avoid sitting on low furniture, like I said before. Avoid standing activities that involve rotating the body forward. Sleep in supine, like I said before, with abduction pillow. Do not bend trunk when standing up from sitting or when sitting down into a chair. And avoid prolonged sitting for greater than an hour. And lastly, our 6 take-home points include: begin physical therapy early for better results and a shorter recovery time.
And also, you can use aquatic therapy mixed with land therapy to have good lasting benefits in total hip arthroplasty patients.
It's important to begin resistance training early in order to increase muscle strength and functional performance, because these results have been shown to be better than gym alone.
Cardiorespiratory fitness, especially at high intensity, can increase ambulation efficiency and duration. It's also important that comorbidities such as osteoporosis and emphysema may slow down the recovery process, so always realize that. And elderly patients may have limited recovery ability due to age-related changes, as well as their comorbidities. And here's our reference page for your information.